Hello, good afternoon, everyone. Thank you so much for joining us today. My name is Alice Nelsner, and I'm CEO at the San Bernardino County Medical Society here in Redlands. We are very, very excited to continue our clinical education webinar series. This is session number 7 on mental health, depression, and the pursuit of happiness. Our title says for adults and teens, but we should actually add and providers, as I understand from our presenter today. So we're going to add some additional elements here to the presentation, which will make it really exciting for all of you as providers to be a part of. I am very, very honored to introduce our presenter, Wadsworth Murad, DO, who is also this year a member of our board of directors and our CMA District 2 delegation. So I would like to officially introduce him and provide you with his background. Dr. Murad graduated from Western University of Health Sciences in Pomona, California. He obtained his family practice residency training from Burbank Community Hospital, LA County, USC, Los Angeles, and his psychiatry residency training from Iowa State Hospital in Iowa. Dr. Murad has been a practicing psychiatrist for over 25 years. He cares for all ages and all psychiatric illnesses and does not specialize in any one area. He is trained and board certified in family practice as well as psychiatry, which gives him a unique perspective and appreciation for a person's overall well-being and care. As Associate Professor of Psychiatry at Loma Linda and Western Universities and Site Residency Training Director at Patton State Hospital, where he serves as Chief of Professional Education, he is intimately involved in the training of doctors and medical students. This keeps him current and up to date on the latest advances in the field of psychiatry and medicine. And of course, he can serve his patients much better that way. I also do want to note that Dr. Murad is a past officer and president of the Osteopathic Physicians and Surgeons of California from 2020 to 2021. And he holds so many academic appointments and professional certifications. So we are very, very honored to have you here with us today, Dr. Murad, and we're going to turn it over to you.
Very good. Good afternoon, everyone. I hope everyone's doing well. Just a little clarification on my background. Though I'd worked for many, many years at Patton State Hospital, I retired from there in 2019, but I have maintained a private practice of psychiatry in Redlands with Dr. Paladugu at Inland Psych Redlands. And we were helping take care of patients both inpatient at Redlands Community Hospital and outpatient in the office. So I've been with her since 2006. So even though I was working at Patton, I was also maintaining my private practice part-time. And then when I retired from Patton in 2019, I went to full-time in the office. So I'm working full-time in the office as a general psychiatrist at this time. And our title, though, it's really to address the mental health needs of the primary care physicians. So as was pointed out, I have background in primary care. And I did that for 5 years before going back and doing a residency in psychiatry. But primarily, I've been doing psychiatry in the last 20 years or so. That's what I do currently. So let's get into our slides here a little bit. And unless something's pressing, I would ask you to hold the questions till the end. Depending on how many people we have, you may be able to take a question here or there in the middle. Can you advance a slide, please? All right, so what I wanted to do here is to help provide primary care doctors with what we would see as the most common psychiatric conditions that may present, understand how to treat them and various treatment modalities, and when is an appropriate time to refer to either psychiatrist, psychotherapist, psychologist, and what might be the reasons to do that and when. Next slide, please. So I have some stats that we gathered from the CDC website that I think might be helpful to just kind of touch on a little bit. As you all probably know, a lot of mental health issues come through the door at the primary care doctor's office. That's where they first are typically seen, and then addressed maybe with medicines or referral out to see us or a psychotherapist. But a lot of the conditions that are seen are first and foremost seen in the primary care doctor's office. So you can see that the prevalence of adults in the United States is something that's pretty high. Adults with any mental illness, about 22%. Adults with serious mental illness, 5%. And we may touch a little bit on what the difference is between just regular mental illness and serious mental illness. And anxiety and worry, although only about 12%, I would say probably that's a little bit low. That's probably more. Most of what I see in my office is primarily depression, anxiety. I see about 25% of kids, but I do see all age ranges. And so it's run-of-the-mill depression, anxiety. About 1% is a serious mental illness of bipolar schizophrenia. Next slide, please. So again, breaking down the data for adolescents and children. So they talk about youth, but really we're looking at primarily, I think, adolescents here, which would be age 12 and above. Children would be under 12. And unfortunately, we've seen a really high percentage move up in the statistics for recently. So when COVID hit in 2020, with all the lockdowns, this really impacted the teenagers in particular. So because especially the girls, because they're used to being social, and when they were locked down and kept locked at home, not able to socialize normally, we had a really big uptick in the trouble with anxiety and depression with those girls. The boys, not as much, because they can keep socializing, doing gaming and things like that, but the girls, they needed to have that social interaction, which was really restricted. And even when the restrictions were lifted for going back to class and going back to socializing, they still have fallout from that. But you'll see from this slide that there's percentages is pretty significant. The thing that is really disturbing and upsetting is that the hopelessness and suicide troubles with kids, particularly the teenagers, has really dramatically gone up. Next slide, please. So what we're looking at here is simple depression, but we would classify these as major depressive disorders, generalized anxiety disorders, substance use disorders, psychotic disorders, and neurodevelopmental disorders. So I'm going to touch on those with the DSM-5 TR criteria and how these are typically diagnosed. Next slide, please. And one of the impediments we have to treating them is that oftentimes people don't want to get help. They want to minimize what's happening with them, or they may not even recognize it. And if it is recognized, it's probably for instance, with kids, it's probably by the parents or with school. So academic or behavioral problems is what prompts them to be brought in and seen. But even with adults, and probably more so men over women, they don't recognize they have a problem and unfortunately, they all feel that this is somehow a weakness, which is an unfortunate problem that we see. It's not a weakness that you have these troubles, and we have to do a lot of educational stuff to help them understand that, like your vision, it's not your fault you can't see. And sometimes that requires a prescription, that being glasses, in order to see well. We'll touch on that a little bit more also. So we have to deal with the troubles of reluctance and insight regarding these conditions and overcome that to help them to be recognizing of and desiring of treatment. There's also some embarrassment that can occur. A lot of people don't want to be seen in the psychiatrist's office. They may be seen by somebody that they know, and that looks like an embarrassment. So that gets in the way of treatment as well. With telemedicine, about, I'd say almost half of the patients I see or through webcam, which has its pros and cons, but that helps with it somewhat. Next slide, please. So just looking at depressive disorders, so in depression, you can have a loneliness and sadness, and I think everybody at some point in their life is going to experience both depression and anxiety episodes. But what we're talking about is where it changes their level of functioning to impair them. And so just the symptoms of depression don't necessarily mean they have to be treated, but it's how long they have it and how much it impairs their functioning, socially, occupationally, and otherwise. So we're looking at persistent feelings of sadness or emptiness most of the day, loss of interest or pleasure in almost all activities, changes, appetite changes, sleep disturbance, fatigue, feelings of being slowed down, which we would call psychomotor retardation, or sped up psychomotor agitation, feelings of work over more than 2 weeks. Slide, please. With all psychiatric illnesses and diagnoses, the criteria is that conditions are not due to another explainable cause, like substances, a medical illness, or side effect of other medicines. So with regard to depression troubles, we're always looking at the severity of the symptoms and how impactful it has on their function. And it also depends on their willingness to accept treatment. We get a lot of people come in, they may recognize they have a problem, but they don't think it's bad enough that they would want to take anything. And again, that part of that is a stigma that they have in the back of their head that somehow this is a weakness and that they should just be able to overcome it. First line treatment, of course, for things with depression and also anxiety disorders is SSRIs. Wasn't going to really go into too much of the medicine effects and how they work, but it might be something to look at. But if they have comorbid conditions, we might select a medicine that would help with the comorbid illness. Unfortunately, I see quite a few patients that have diabetes that's poorly controlled. And if the diabetes is not well controlled, then it impacts their mood symptoms. And I explain it to them that this is like, it's like their blood sugar is our gas for the car. So sleep and food are gas for the car. If there's no gas, the car doesn't run. So then they can't focus, stay on task, function. And if they have a feeling of needing the blood sugar, so we're filling up the tank and we're adding gas tanks into the trunk and we're weighting the car down. But if the gas doesn't get from the tank to the engine, then it's not going to work very well. And I explained to them that our medicines tend to be like the oil we put into the engine. Doesn't matter what kind of oil we use if there's no gas getting there. So we have to address those things at the same time with helping them to recognize the importance of good blood pressure and blood sugar control and other control of their other illnesses, comorbid illnesses. Oftentimes we will use more than one medicine to help them with their symptoms because we're addressing it through different chemical pathways in the brain. So for instance, I might use lithium as an augmentative medicine for someone with depression, even though they don't have bipolar disorder. And people will recognize lithium, oh, that's bipolar, that's for bipolar. I don't have bipolar, and we have to explain to them about the use of those things. Sometimes they don't respond to medicines like we would like, and other options have to be discussed, like ECT or transcranial stimulation. And then, of course, we all work with them, psychotherapists. So we want to approach it not just with medicine, but also with psychotherapy to help them to have the support, with the idea of trying to get them off medicine eventually, with working on improving their skill set with psychotherapy. So the example I will use for patients is that I tell them, this is like you're in the ocean, but you're not a good swimmer. If the water is calm, you can kind of get around okay. Water is stormy, you're fighting the waves, and with a panic disorder, if a wave overtook you, that's what a panic attack would feel like. And they have to learn how to swim, but it's very hard to teach them how to swim through drowning. So we use medicine like a life vest, while we're also working with a therapist to learn how to manage the symptoms better. And the goal is not to wear a life vest, the goal is to learn how to swim. And once you master that, then we can back off on the life vest. Next slide, please. So for bipolar disorder, we have a few different types, but really, I mean, we're looking at either mania or depression or the combination of the two. And it's the severity of the symptoms that dictate what the diagnosis is. So they have to have the symptoms for a period of time, generally 2 weeks or more of symptoms. If it's less than that, then maybe it gets into a less severe type of illness like cyclothymia. And with bipolar and with depression, you can have psychotic symptoms. So this is where we use qualifiers to say they either have or have not psychotic symptoms, and then how long they have it, how impactful it is, how severe it is. I even have some bipolar manic patients that are able to be functional. So it's just a matter of getting their symptoms under control, learning their cycles, and helping them to manage those troubles when they have them. So obviously manic symptoms are mood swings, pressured speech, rambling, impulsive behavior, and the depression. Next slide, please. So treatment, of course, is the mainstay is using a mood stabilization. Lithium is the gold standard. But we also use a lot of seizure medicines, which seem to help stabilize the nerves so that they're not so reactive. So that also, this also works well for people with anxiety. So we will often use seizure medicines like valproic acid, Tegretol, Trileptal, Neurontin, Topamax, lamotrigine. And I use a lot of lamotrigine in patients with associated anxiety disorder because it works very well. And then, of course, sometimes we have to deal with the manic symptoms of using an antipsychotic or a benzodiazepine like clonazepam. Next slide, please. So with anxiety disorders, now I classify myself as many different levels, including eating disorders, post-traumatic disorder, OCD, panic, social anxiety. These to me are all basically the same problem with a different label. They all have severe anxiety, which is disabling, and in different ways. And we treat them similarly. So next slide, please. So unfortunately, there's a lot of kids, as we see here, that have anxiety disorders. And previous slide I mentioned from CDC database stats that unfortunately anxiety is getting worse in kids. And we could speculate as to why that's occurring, but again, we're not trying to understand the cause necessarily, but just treat the symptoms and help them to learn how to manage it better. But anxiety in its essence is excessive anxiety and worry, basically fear about things in their life. And it manifests with symptoms of restlessness, easy fatigue, poor concentration, irritability, short fuse, muscle tension, sleep disturbance, feeling of doom. And to be able to diagnose it as a generalized anxiety disorder, we need to have it at least for 6 months or more. Anything less than that might be diagnosed as an adjustment disorder. And they have trouble controlling it. Next slide, please. So this is a persistent fear of social situations where embarrassment may occur, anxiety about being judged or scrutinized by others, avoidance of things that would trigger or cause them anxiety, and the physical symptoms of distress where you get sweating, trembling, rapid heart rate. Again, like panic, the panic symptoms. Now, general phobias can have these as well. So agoraphobia, and they're avoiding certain things, but basically there's a trigger that's involved. Sometimes we know what it is, sometimes we don't. And that may be one of the things that we ask them to try to get for us, to write down when they have these episodes so we can understand what may be triggers, because they don't remember them. And if they can write about it when it's occurring, that helps us in how to manage it. The fear that they have is in a disproportionate level to the actual threat. And again, time period of greater than 6 months. impacting their social and occupational functioning on a daily basis. Next slide, please. So with panic disorder, it's a specific trigger, recurrent unexpected panic attack, where they get fear, intense fear and discomfort. And like I said, I explained it to them, this is like you're drowning. So it has that same kind of feeling. Sudden onset, severe palpitation, short of breath, chest pain. And there's no obvious trigger or reason, but it occurs. And what happens with these people in particular is that typically they have a traumatic event in childhood and they start having anxiety, and then they push it off, push it off, push it off. And as time goes, it gets worse and harder to manage. And for some reason, about age 30 seems to be the time when the anxiety, the panic really takes off. And oftentimes that's when they first start having panic attacks. And I think that's just physiology. I tell them you can run the mile when you're 17, you don't do the same at 30, even if you're in perfect physical health, your ability to compensate gets harder. So then you have more of these symptoms. And then as the anxiety goes unchecked, then you can get depressed because it feels hopeless. They have a feeling of being trapped. And so then they avoid things, and then they get more and more isolated, restricted in what they do and how they do. So one of the criteria is significant distress or impairment in social, occupational, or other important areas of functioning. And then they can develop agoraphobia, although it's not 100% necessary to have panic disorder. You can have it with or without agoraphobia, where there is a specific fear of a situation where they feel like they can't escape. So, stage fright might be a similar kind of thing. So again, it's a type of anxiety disorder. So people with hoarding would be kind of an example of this. They have severe anxiety, and then usually it's because of a loss in their life somewhere, and they keep things. So they collect stuff, and they can function outside, but in their home environment, they do these things they don't make sense to most people, but it has to do with the earlier trauma they experienced. Next slide, please. So OCD, again, basically is an anxiety disorder where they have a recurrent persistent thought or urge. Sometimes it's just an image that they have that's intrusive and unwanted. And then that causes severe anxiety, distress. They can't seem to control it or get rid of it. And then they have a compulsive action or behavior to try to extinguish that thought. And that gets to be repetitive. So these things happen in many people. Some of them are not easily noticed. I have to specifically ask that question in my assessment of every patient. I ask them about OCD symptoms, but I've had a lot that if I don't ask it, they don't tell us. So you may not recognize that they can have OCD symptoms and not manage that part of it because they don't tell you about it. They don't think of it as being a problem. Next slide, please. So eating disorders, I classify as an anxiety disorder because they all have a lot of anxiety associated with them. So they have poor body distortion or image, and that makes them anxious. So then they do behaviors to try to correct that, which is eating disordered symptoms. So they're restricting, or they have binging, purging, but they may not have those full type of symptoms. They still have an eating disorder. So we have to also question about that. But really, we're dealing with an anxiety disorder. Next slide, please. So PTSD, another type of anxiety disorder. This typically has to do with an exposure to some sort of traumatic event. Then they get intrusive and recurrent involuntary distressing thoughts or dreams about these things. So one of the things we ask about is their sleep, because one of the ways it manifests is impaired sleep, nightmares, can't sleep, and they have recurrent bad thoughts or recurrent intrusive dreams that wake them up at night. And then, of course, if they don't sleep well, then they don't function well. So if they have those kinds of troubles, we basically are treating it as an anxiety disorder. We may have to use sleep aid medicines or things to help them to sleep. But one of the troubles with their sleep is, especially if they have anxiety, is they can't sleep at night. And this is very true of women in general. And the way I explain this to people is women in general, they have a different sleep time normally than men. Men sleep early, women sleep later. And the best, most restorative sleep for women in general is between 3 a.m. and noon. So I get them to see if they can sleep at a different time. If they can sleep at a different time, I don't need to drug them to sleep. It's a much better quality sleep. And then we don't have to worry about side effects of the medicines to make them sleep. But when they have PTSD, they definitely have very much trouble sleeping at night. So people with anxiety in general, they don't sleep well at night, particularly women, because it's if they don't feel safe. They don't feel safe in their environment. But if they can sleep in the day and not have that distressing trouble, that may be all we need to do to help them, but they got to sleep. Next slide, please. So again, treatment for anxiety disorders is one, identifying what is the underlying trigger or cause, trauma, and try to address the symptoms. But really, we're trying to first control the symptoms, and that's where what medicines we use might be the decision on what medicine might use might factor into that. And people, in particular women that are anxious, they don't like medicine. They don't like the feeling of being drugged. It makes them feel vulnerable, can't protect themselves. So then they get into not wanting to take medicine. And they're also extremely sensitive to medicine side effects. So if we start them on a typical normal adult dose, they may have side effects. And as soon as that happens, they will not take that medicine again. And it's impossible to get back onto using it because they've had a bad experience. So we typically underdose to start with. I don't want them having side effects. And if they take something that really is not giving them any trouble, then they may be more accepting of gradually increasing the dose to where we can get to an effective dose to help them to resolve their symptoms. But really, I put in their mind, this is not the long-term treatment plan. We're not trying to give you a life vest. We're trying to get you to be able to work with a therapist to learn how to swim. And once you master those skills, then we can back away from medicine so they don't have the feeling that it's hopeless, I'm stuck on these pills forever, particularly if they have trouble with them, which typically they do. So that's where treating anxieties or disorders are more difficult than any other condition we have. I also try to get them to use other resources, and that's where the therapy comes in. I recommend a book called The Anxiety and Phobia Workbook often, which is a self-help book. But I explained to them, working with these self-help books, it's really like learning anything. And if you could, for instance, if you wanted to learn how to play the piano, you might be able to watch YouTube videos and see how to do it. But without a piano teacher watching what you're doing and refining your skills, you're not going to make changes. And you're going to jump around and not do it in an organized way, and you won't practice. But if you have a coach or a therapist or a piano teacher watching you and seeing what you're doing and practicing and seeing where you're making mistakes, you're more likely to progress with that, rather than just relying on a self-help book, which you may or may not do, and you may or may not sit with it well or stay with it. Next slide, please. So neurodevelopmental disorder troubles, which are a lot of times come into the office primary care. The kid's got ADD symptoms or ADHD symptoms, oppositional defiant disorder symptoms, or autism. And autism now is on the rise. As you know, we're seeing more and more kids with autistic spectrum disorder troubles or Asperger's. And so then those get a whole unique, different challenge. And unfortunately, there's a lot of comorbidity. So you can have a kid with autism that also has attention deficit disorder, or a kid with attention deficit disorder that also has oppositional defiant disorder. Next slide, please. So those create a unique challenge in how to manage and treat them. So just for attention deficit disorder, we have inattentive type, hyperactive type, combined type. The combined type usually, or the hyperactive, they usually have impulsivity, which is what gets them into behavioral troubles. So the kids with attention deficit, inattention troubles, they tend to be wallflowers. They can slip through the cracks and not get noticed. They can pass, getting their grades adequate to pass, but typically these kids are very smart. They're not, they don't have trouble with attention or understanding. They have trouble with staying on task, easily distracted. And unless they're hyper, you don't notice it. Or they have behavioral troubles, you don't they're not as easily noticed. Girls with this tend to have mostly the inattentive type, not the hyperactive impulsive type. Boys more so of the impulsivity troubles. And so that's when we tend to get to see them. And oftentimes they're going to the primary care doctor first before they come to us. And so, they may be started on some medicine. Also with that trouble, those kids get anxious and depressed, very commonly associated. They have also depression, anxiety. And I explained to the parents, this is like your kid was born, but they don't see well. Well, they don't know they don't see well. They think everybody sees like they do. And if you don't know what it is to have trouble with vision, you won't understand what they're talking about. And then it gets to be, well, you just need to, do your work. You just need to do this. And it gets to be punitive. And then the kids, because they can't do it, they tend to give up. And then they get depressed because they can't fix it. There's no way to fix it. They don't even know what they're doing wrong. And I explained to the parents, a lot of parents don't want their kids medicated. So what are we going to do with them? So that we have to use other modalities and help them understand that this is a disability like your vision. If you don't see well, would you withhold your kid from getting glasses? Of course not. So you have to look at it in the same light. And glasses are a prescription. So what we want to do is help them to be functional. As they improve with age, maybe learn how to do things better with working with a therapist. But at a young age, therapy does not work with them. They can't sit and stay with it or even understand how that works. So they don't have the ability to learn what to do and have the cause and effect part of it understood. So this is a persistent inattentive trouble with or without behavioral problems. And they can't organize, follow through, so they get procrastination. Typically this has to be occurring for over 6 months. So this is where we get into trouble with understanding history. The time that I see these kids mostly is when they hit 3rd grade. So they can kind of get through between kindergarten, 1st, 2nd, in part because they have more one-on-one attention and help. But when they hit 3rd grade, they're expected to do stuff more independently. And if they didn't have the basics learned, they're just going to really struggle and they're falling behind. And then they get into having the anxiety, depression troubles more so. So it's 6 months in more than one setting, home and school, negatively impacts their social, academic, occupational functioning. And this can proceed and continue into adulthood. And if they're smart, they can kind of get through things. But when they hit adulthood, they graduate high school and they have to be doing college, which is a higher level of expectation, or work setting, they just can't function. They can't do it. And then you have more of the mood disordered symptoms that make it worse. The symptoms, according to the criteria, they have to occur before age 12. Very difficult in adults to get that history. And the kids themselves, the adults, I can't tell you. They really don't know. Next slide, please. So the mainstay of treatment, gold standard of treatment for attention deficit disorder is stimulants. The way the stimulants work is they stimulate part of the brain that's lacking stimulation and it has a calming effect. Versus if you give a stimulant to a person who does not have that, they would be amped up like they had an espresso. So that's one of the ways we know. It's a provocative test. You give them a stimulant, see how they do. Now, most people, even if they don't have attention deficit disorder, will feel better with a stimulant. Okay, so that's where it gets a little tricky. Kids don't like medicine. They don't want to take it even if it helps them. They don't like the idea of taking medicine. And so that becomes a bit of a problem because of compliance troubles. And if they don't get it in them to help them, then it doesn't work, obviously. There are some non-amphetamine stimulants that can be used. Quite frankly, they really don't work very well, if at all. So, you might convince the parents to give them a non-amphetamine type stimulant, but in reality, they're not going to work very well. So they're going to have limited benefit. Now, clonidine is a little bit of an exception because clonidine helps with the impulsivity part, but it's very sedating. So we have to take it at night. And sometimes we have to use that at night in addition to a stimulant. So that they sleep well and then they have the carryover impulsivity control better in the daytime. But there are limitations with those medicines as well. So with the amphetamines, we have the query cures, as you know. It doesn't matter what type of amphetamine or stimulant type we use, they only last about 4 hours. Then we get into trouble with having to maybe take a secondary dose in the afternoon. Later we take something, more likely we're going to have trouble with getting into sleep time. Sometimes we use some other medicines like Wellbutrin, SSRIs, because of associated anxiety and depression symptoms, sometimes lithium. Oftentimes with kids, I'll use Tegretol. And then, of course, we try to educate the parents and the kids, depending on their age, about the condition, what's causing it, and what may be some ways to help them with it. I often recommend a couple of books. One is called Driven to Distraction and Answers to Distraction. Teaches about the symptoms of it, so the parents have an awareness, also the child if they're old enough to learn. And then the Answers to Distraction teaches them some skill sets, so we're not just relying on pills again. Next slide, please. So with oppositional defiant disorder, and oftentimes this goes along with attention deficit disorder. This is a pattern of anger with frequent temper tantrums, angry outbursts, argumentative behavior, defiance, blame shifting, vindications, and again, same sort of thing, more than 6 months, and interfering with their academic or their home situation, so they're getting in trouble a lot. And this is one where clonidine is very helpful, but also the anti-seizure medicines like Tegretol in kids that we use for kids work very well. But like I said, there's often comorbid depression, anxiety, and attention deficit, where we might have to use more than one medicine to help these symptoms. Psychotherapy, not very good. They just don't have the ability to stay on task and understand, and they don't have the motivation to do it. So a lot of parents want them to go into therapy. Doesn't really work. Next slide, please. So psychotic disorders. Now, again, we're lumping things in here. Psychotic is where they have hallucinations, illusions, paranoia, those sort of things. Schizophrenia is the gold standard when we use in comparing with mood disorder with psychotic symptoms or bipolar with psychotic symptoms. Schizoaffective disorder is a combination of mood and schizophrenia types of things. We also don't want to forget about with these things postpartum psychosis and postpartum depression or anxiety, because those often happen too. And those are a whole different thing to how to manage. And as we know, this is partially hormonally related after they've had a child. And then we get into issues with how to manage those, particularly if we're going to medicate them if they're nursing. Next slide, please. So with schizophrenia, and this, again, these are the criteria that we'd use for any psychotic disorder. This is presence of delusions, a false fixed belief that's not based in reality. Hallucinations can be any type: sight, smell, taste, hearing, touch. Those could be perceptions that are without an external stimuli. The most common is auditory voices, but they can have any of the other ones as well. If they have visual hallucinations, it's a clue to some metabolic problem, because that's usually what causes visual hallucinations. So if they're complaining about visual hallucinations, you want to look for a metabolic reason. Disorganized thinking, incoherent speech, negative symptoms, which are the things that are taken away from a person. So reduced emotional expression, lack of motivation, social withdrawal. And they have functional impairment that lasts more than 6 months to have a schizophrenia or psychotic disorder that's of that level. Next slide, please. So treatment is, of course, antipsychotic medicines. And there's a whole range of different ones that we use. And then psychotherapy can sometimes be helpful, but depending on their impairment, I mean, I have some schizophrenics that are very functional, they can work, but they need to have their symptoms controlled. The goal is not to eliminate all the symptoms. The goal is to make them functional. So just because they're hearing voices doesn't mean they can't function. So unfortunately, people think, oh, I got to get rid of all the voices and delusions. No, that's not necessarily true. The goal is to make them functional without making them overly medicated. And that tends to be a little bit of a tricky thing. Of course, that would be one of the ones that might be harder to manage in a primary care office, but it would be appropriate for referral. Next slide, please. Substance use disorder. Okay, now this is more and more becoming an issue with fentanyl and people using substances they're not supposed to. So there's differences between use, dependence, and abuse. Next slide, please. Unfortunately, many people use substances to self-medicate. They feel like they can control their symptoms better by picking what they want to use and not have to go in to see the doctor to get the prescription done and have to deal with the social effects of being labeled an addict. The substance use disorder criteria is any substance that you want to pick from: alcohol, marijuana, fentanyl, you name it. Okay, the criteria are the same for all of them. They have impaired control, there's social impairment, they have risky use, they can develop tolerance, which is a common problem because they're having to take more and more to get the same clinical benefit that they think they're having, and then develop dependency, both physiological and psychological. Because they like to self-medicate them, they don't even realize what they're taking and what they're doing. And then they tend to increase their use of it. One of the problems with, especially if they're using street stuff, is it can be cut with things. So then they may be getting a mixture of different substances in there. And unfortunately, there's this belief that marijuana is good for anxiety. This has been studied, multiple studies have done that show no benefit of reduction in anxiety symptoms. What it does do is make them forgetful. They don't remember they have a problem. So then they use in thinking that it's helping them, but really they're not remembering what they're doing. And then of course, you have the weight problem because it makes them hungry. So now a lot of times they won't tell you what they're using, what substances they're using. And you have to kind of dig it out of them because that makes a difference on what we do with them, because they may have a drug-drug interaction depending on what they're using. The continued use, despite knowing that it's bad for them, they can't control it. So they may get a DUI or have risk of loss of job. They can't control this. And so then they continue to use and abuse and get into trouble. This is a duration of symptoms within a 12-month period for meeting the criteria. Next slide, please. Severity is the most important part of this in terms of how they're functioning and how often they have to use. So we want to know how often they're using, how much they're using, how they use it, when they use it, and what does it seem to do to help them. And then trying to address that may require detox, may require being in an inpatient program to get control of this stuff, to get it out of their system. But the substances are so easy to get, it's very hard to control it. Alcohol being the worst. And you know, we have to use sometimes anti-abuse or other medicines to try to stop them from using. But really, they have to want to change. They have to want to do it. And if there isn't any pressure from work or home or wherever, very hard to treat these. Sometimes they'll have comorbid depression, very common, particularly with alcohol. Alcohol causes mental depression. And so then that worsens their depression. They don't realize that. Next slide, please. So one of our barriers to treatment is not getting the information. They don't want to disclose it. They have embarrassment about it. So we have to be able to ask that. Sometimes there's, you know, questionnaires we use that have them fill out, but they're not going to, sometimes they don't tell you. They're not going to, they don't often own up to what they're doing, or they don't think it's a problem, so they don't need to disclose it. Lack of insight, poor motivation, worries of stigma. Next slide, please. And of course, one of the serious risks we have is accidental overdose. So, you know, people right now are having Tylenol overdoses. They don't think it's dangerous or risky. So they don't realize that they can accidentally overdose on something. And sometimes if the stuff they're getting on the street is mixed with something, they may have an accidental overdose because they didn't know that it had been cut with something. So they don't realize it. And of course, if they don't tell you that they're using or abusing something, then you won't think about it and have that worry or have that conversation with them. Next slide, please. So just some stats here from 2025 drug overdose deaths, and you can see the number of cases is going up over time, and it's accidental. Sometimes it could be not accidental. They want to be suicidal. They want to do it. But this is a risky trend that we have, and we have to ask those questions to make sure of what they're taking and the risks so that they identify that they could accidentally hurt themselves without realizing it. Next slide, please. So suicide rates are on the rise. We think this is tied to stress of our situation in the world these days. Definitely things have gotten worse with COVID. Even though COVID has kind of settled down, we still have all of these troubles. And unfortunately, the substances on the street are so easily to get. People get them accidentally overdosing, but sometimes they're so depressed and hopeless that they look for this as an option. And one of the things about suicide is that someone who's truly suicidal, they don't look suicidal. They actually feel at peace because they have a plan what they're going to do. They don't tell you they're suicidal because that's their plan, and it gives them a peace that they have something they're going to do, even though it's not good for them, and there's other options. So they will look like they're doing well. So that can be a risk factor and problem to keep track of. Next slide, please. Another thing that you'll see in the office, primary care doctor's office, is personality disorders, which can be very challenging in how to manage. So that may be their only trouble, though typically if they have a personality disorder, they also have associated mood disorder troubles. But one of the ones that's really difficult is a patient with borderline personality disorder, because these are our cutters, and they are cutting themselves to relieve emotional distress. They're not suicidal. So, and they hide it, so you don't know about it. So unless you do a full body exam, you may not see that they're cutting themselves or scratching or burning themselves. It doesn't have to be cutting. It can be any type of injury to themselves, and they're very good at hiding it. So you have to look. Another one that's difficult, and they don't believe they have a problem, or they have this interpersonal problem of unstable and intense interpersonal relationships. You're either all good or all bad. And they have impaired and unstable self-image. They don't feel good about themselves, which lends itself to the mood troubles. Very impulsive, intense anger, even paranoia, dissociation. So you'll see these, but they may not be obvious. But if you get what we call a countertransference response, they bug you. They don't feel right. They make you upset. And that's usually because you're dealing with a borderline. The narcissistic are almost as bad, probably not as bad, but bad enough, where they have grandiosity. They think they're great. They think they can do whatever they want, and this fantasies of unlimited success. They may feel that they know better than you with treatment. They are lacking of empathy, and they become arrogant. Another one that you may or may not see, but most not typical, is a sociopath. They don't care about anybody but themselves. And they have this, they can be very charismatic. Again, these personalities sort of very difficult to treat. They don't accept treatment or medicine, and they don't respond well to medicines in general. They just become hard to manage. With their other associated physical troubles you're trying to help them with. Next slide, please. Don't have any good treatment options for personality disorders. Sometimes psychotherapy. For borderlines, there is a type of therapy called dialectical behavior therapy, but the patients have to be really motivated to work on that with them, and it's a long-term process. Sometimes we can get them better with using medicines, but typically they don't like medicines and not willing to take them. Next slide, please. So when to refer and to who? So if they have comorbid medical problems, probably best to refer them to a psychiatrist. Some insurances require the patient to see a psychiatrist before they can see a therapist. almost all of the patients I see, with the exception of a few, I also want them doing psychotherapy. Some insurances can allow self-referral, some require to go through your primary care doctor office. But if they're willing and wanting to get help, then we should get them the help that they are desiring. With postpartum depression, anxiety, we have to watch for the psychosis. There's a risk of self-harm and harm to the child. So if there's an imminent concern, obviously we want them to go to the emergency room, and they may need inpatient care as the initial treatment. Same with suicidal or homicidal ideation. If they're severely psychotic, now it's a matter of what are the risks here. They're going to act out or cause harm because they're delusional or because they're hearing a voice telling them to do something. That's a little bit more of a judgment call. Obviously, the fail-safe is to get them through an emergent situation first, and then if they can be managed outpatient, then sent to follow up with a psychiatrist or psychotherapist. Obviously, comorbid illnesses, I think you need to send them to the psychiatrist who has the medical background to how to manage the other comorbid troubles. Simple depression, anxiety may or may not be benefited with medicine, and just simple psychotherapy should be fine. That should help them. Typical things like grief, it will resolve in about a year. Situational triggered causes of depression or anxiety usually respond with an SSRI or something like that. May or may not need additional psychotherapy. It just depends on how long they have impairment. General rule of thumb with particularly antidepressant anxieties medicines, I tell them minimum of about 9 months. If we're going to start a medicine, I want you to take it for 9 months, because statistically there's a very high relapse rate if we stop the medicine earlier than that. So a lot of times they'll take a medicine, they start feeling good, and then they quit the medicine, and then they fall back again. And sometimes when we restart the medicine, it doesn't work. So then we have to go into another medicine or other things. With the cognitive troubles like dementia, and I see quite a few referred to me for that trouble, there isn't a lot, as you know, we can do about dementia. And then what we're doing is mainly sedating them, but antipsychotics are contraindicated in elderly people with dementia. So that creates another problem to have to address. Next slide, please. Really want to try to recognize things early so we can intervene early, because we'll have a better outcome if we can intervene on it quickly. The longer we wait to get treatment, the harder it is to manage, and they have developed bad habits. So then it's harder to fix those, to undo them. We want to involve other support services like school involvement, other family members, to get as much support around them as possible so they can resolve the troubles quickly. And obviously prevention is worth a pound of cure. All cases of mental disorders have in the criteria the exclusion of a substance or other medical condition first as the etiological cause. They have to be ruled out first. And then we address the psychological troubles separately. Next slide, please. All right. I thank you for your attention. I'll be happy to take any questions.
Thank you so much, Dr. Murad. That was really a great overview, as well as some more in-depth areas that we all might want to explore. So I'm just checking here to see if we do have any questions in the chat. It does not look like we do, which surprises me. That means you covered it all.
Well, maybe. Certainly, if there's somebody has a question at some future time, I'd be happy to help them. They can call the office or leave us a message. Since I don't have an office email, I don't want to give my personal email because I don't look at it very often. I won't get to answer a question quickly. But if someone had a pressing question, maybe Allison, you could get it from them and direct it to us.
Absolutely. If anyone does have a question for us, I am going to put my cell
So
number
you see
in
some in
There
the
is one
chat.
question in there,
Yeah.
Allison. It just came through.
Oh, fantastic. Yes, here, I'll read it aloud so everyone who's maybe not seeing their screen can hear it as well. It's from Elizabeth Ortiz. Going back to ODD, it was mentioned that psychotherapy does not work. What would work best for ODD?
Yeah, that's a good question. Well, oftentimes they don't just have pure ODD. So they're often distressed because of it. They're getting in trouble because they're acting out in school. So structure is what we use for kids with both attention deficit disorder and OCD, ODD symptoms, oppositional defiant disorder. Because if they have structure, it will help them. But one depends on the age, what the behaviors they're actually doing. Is it only at home, which is a common trouble? I get the parents complaining about their behavior, but in school they do okay. So that suggests the structure is different. And if they have the structure similar to what they have at school, then the behaviors are less. But the parents often are just fed up, burned out with how to deal with this kid. Oftentimes, the parents need to have the therapy to recognize how to manage things at home better, because they become punitive and restrictive. And then, of course, then the kid rebels about that stuff. But unfortunately, we don't have a lot we can do with that. Like I said, sometimes we'll use a anti-seizure medicine like Tegretol or Clonidine, which help with impulsivity troubles. And sometimes they can do some limited type of therapy with someone. And again, depends on the age. Adolescents maybe benefit a little bit easier than kids in elementary school because they just don't have the ability to sit and understand cause and effect. So that's the basis of psychotherapy, is helping them recognize what they're doing and then see that there's a consequence to the behavior and to learn how to manage it differently. But they're not going to hear it very well, and especially if they have comorbid troubles like attention deficit disorder. So we want to address those other associated symptoms as well. Hope that answers your question.
Wonderful. Here, Dr. Pandit also has, well, actually, we'll go back to Susan, who had a question before that. For personality disorder, for folks who cut themselves, how do we assess if that patient is at risk of suicide?
Yes, good question, because they could also be depressed, but generally, if they're not having depression and true suicidal thoughts, it's personality trouble. They are not cutting themselves because they want to die. They're cutting themselves because the physical pain of the cut removes the emotional pain. Okay. And they're not cutting in a place that's typical for someone who wants to die, like slashing their wrists. They'll cut little fine cuts, like with a razor blade, in very small areas. They may not even bleed. It's so tiny, but they feel the physical pain of it, and that is helping them deal with their emotional pain. So we want to really address the emotional pain, so then we stop doing the behaviors. Okay, but they may have to do intensive type of therapy depending on how old they are, when they started doing it, and why they're doing it, how frequently. So those are things that you have to kind of assess all the dynamics of it. Again, that's beyond the scope I would expect in a primary care doctor's office. That needs to be dealt with a psychotherapist, not so much a psychiatrist, but also sometimes in case they need medicine to help them with that impulsive behavior, because it's an impulse.
Wow, I've never heard cutting explained that clearly before. Seriously, that was really, really helpful. All right, now Dr. Pandit's question. I work in primary care, and many patients who need to see a psychiatrist are not willing to see one. Do you do peer-to-peer consults?
Yes, I do peer-to-peer consults, and you're right. They don't want to see because of the stigma. They feel like it's, somehow they're weak, or, they don't, they're really afraid of analysis. They don't want to be kind of their brains picked. So we really want to try to help them. we're not here to hurt, we're here to help. We're not trying to pick you apart. We want to really understand what are the things that you struggle with so we can help you with those things. And a lot of times I have to put it in a different perspective. All right, you're taking blood pressure medicine, you know, you have a problem, you're accepting, I need help with that. This is no different. You have a deficit in some area. It's, you just don't know what to do. You need to learn. So we want to teach you about it. And not just, you know, okay, I'm going to take blood pressure pills forever. No, we want to learn, okay, what are the risk factors? What are the contributing factors? So that we can get your blood pressure under control by other means, diet, exercise, you know, other things that maybe if those get addressed well, maybe you don't need the blood pressure medicine. But it's teaching, getting them comfortable that it's okay. And maybe a psychotherapist might be your first one that they'd be okay with rather than a psychiatrist. But we have this unfortunate stigma about seeing a psychiatrist. And it's hard to overcome that. It's just a matter of spending time with and educating them about, you know, this is not unusual. Lots of people suffer. In fact, most people don't realize that anxiety and depression are very common. They think they're the only one. So recognizing that this is pretty common. I mean, with the internet access to things now, they can look up stuff and get anecdotal things that are not correct or misinformation, or they may read into it a whole bunch of other stuff that scares them. And, you know, we have difficulty in controlling that access to information, but the information can be cause them to be scared that they're really, you know, hopeless or a bad person or something like that.
Thanks, Dr. Murad. Did that help, Dr. Pandit? If you have any follow-up, let us know on that. And Dr. Case has a question.
Yes.
Yes.
Split custody. Yeah,
Yeah.
that has a whole other set of unique troubles that go along with it, because sometimes the kid is in the middle of custody battle and they're using the kid as a pawn. So they're trying to get custody or increase their custody or get more money out of the co-parent for childcare. Lots of dynamics mixed into that stuff. And it's hard to get both parents in when they're having that trouble. And when we do, we see them fight in the office and the kid is in the middle of it. It's really tragic. And those kind of cases, we try to get the parent to help deal with their stuff separately and not involve the child. And look at the child individually and see what we don't want them to make the child's troubles worse. And the child then has also loyalty troubles. They get involved with that. They don't want to get mom upset and they don't want to get dad upset. And they really in a bind with what to do because, you know, most kids, in matter of fact, don't want their parents split up. Their hope is they'll get back together. That's a lot of them have that. Okay, so they're really placed in the middle. So we try to get the parents to work on their stuff individually. And if they have custody issues, let their attorneys deal with the stuff. Don't get intimately involved and don't use the child as a pawn to get what you want out of the co-parent. Really tough. Those are very difficult ones to manage. I don't think that something can be done very well in a family practice setting because it's too many dynamics involved. They have to work on the stuff, maybe couples therapy, maybe individual therapy to first, and if there's custody or court information that's in the middle of it, really complicated, very complicated.
You know, Dr. Murad, when you see cases like this that are really challenging that come to you, I know every case is different, so it's going to depend on the dynamics of for instance, in this case, the parents and things like that. But do you see improvement with like the children? Do you see things like ODD and ADHD improve if you in the right conditions? I mean,
yes. Now, part of it is we're buying time. So we're trying to get them through a period where they will mature, and as they grow, maturity improves, they'll have better outcomes, and they'll be more willing to work with someone to help them with the areas they struggle. Okay, but we have to get them in so that they can see, all right, we can get better, you can get better. But a lot of it is we're providing time to help them mature. And as they mature, then they have better insight, judgment, and outcomes with behavior.
Interesting, huh? Okay. Do we have any other questions? This is fascinating. Anyone want to just ask something verbally? No? Well, all right. I guess you have covered it all. That was really, really insightful. Thank you so much,
Very
Dr.
welcome. Glad
Murad.
to be here to help.
Well, we
Have a
sure
good
do
rest of the day,
appreciate
everybody.
it. Thank you so much. And we will see everyone next month on October 14th. It's on a Tuesday next month. Normally we have these on Thursdays, but for the next session in our clinical series, which is on orthopedics and arthritis. So we'll be shifting gears, but we appreciated learning about this. Thanks again, Dr.
Good.
Murad.
Thank you,
Everyone,
everyone.
we'll
Have a
see you
good
soon.
afternoon.
Thank you all.
Take care. Bye.
Bye-bye.
All right. Anything else?